Next up, we have the amazing Dr. Goyal, and I will let him take it away.
Thank you. Hi, can you guys hear me? Thank you for sharing that story, Ms. McFadden, Ali. I appreciate it. I always have all the lectures I give have a patient story in the beginning. So you made my job much easier also because this inspires me so much to do what I like to do. I did put together some slides just because I'm a creature of habit. So I'm going to share those slides if that is okay with everyone. I tried to do it a little bit differently than my usual talks this time, and I would be interested in knowing how this one goes. Can you guys see my full screen now?
Yes, we can.
Okay. All right. So I am at University of Alabama, Birmingham. I see a lot of patients with Rosai Dorfman disease. In fact, that is majority of my clinic practice right now. And I have learned a lot about this disease as I was in my fellowship training when we put together our first large series of 64 patients with RDD adults. And then I came here. I do consult on some children. I do get calls and messages about children with various histiocytosis, including RDD. We have a children's hospital across the street, so I work with them as well. So I'm going to try to give a brief overview, but please take what you will from this and we can have discussion afterward. That's really the goal. And I really enjoy being with patients and families and other community members because this is really who we do all this for. So I guess first question was why histio? When I was in my fellowship, I saw my first patient with histiocytosis. And I recall that she had been through many doctors. I think she waited 8 years or something to get a diagnosis. And then when she saw me, I was like, yeah, I know this. I always had a knack for rare diseases. And she was very tearful at meeting someone who knew about the disease. And helping her sort of inspired a very deep commitment in me because it was very rewarding, of course. And so that's when I started working in this field altogether since then. So we'll talk a little bit about what is RDD, how is it diagnosed, what are the treatment options, how do things such as living with RDD. And we're talking about our research study that is in partnership with the Histio Association, and hopefully will give some hope for the future. So let's do an overview of RDD. RDD is a rare disorder that affects the immune cells called as histiocytes. These cells can accumulate in various organs of the body. They can cause damage. It affects everybody differently. It belongs to a family of histiocytosis, a family of disorders called as histiocytic disorders. The old name was histiocytosis, but that has still stuck around. But RDD can behave like a cancer or an inflammatory condition. It was not until 2022 when it was realized that this is similar to Langerhans cell histiocytosis and Erdheim-Chester disease, and this is actually truly a slow-growing type of cancer. The exact cause of RDD is unknown. It can affect children who have some hereditary conditions. There is an ALPS syndrome, autoimmune lymphoproliferative syndrome, that can be associated with RDD-like lesions. It can also occur in coexistence with other cancers such as lymphomas, as well as with autoimmune conditions. It affects both children and adults. So average age, if you compile everything, would be around 20 years at diagnosis. RDD is different than LCH and ECD in that it affects people of color. Especially, I see a lot of these patients ever since I moved to UAB because of the population I serve. Actually, most of my RDD patients are Black, but it can affect all races globally. We don't know the true incidence because it was not being tracked uniformly up until last year or a couple of years ago. and with it's approximately 300 to 400 cases of RDD each year. I think that it is probably the most common, if not one of the most common histiocytic disorder affecting people globally. This slide is from a paper we put together a few years ago from our histiocytosis working group, where we try to spread awareness of the various manifestations of RDD. As you can see, it can affect any organ system from head to toe. So the images on the sides are from actual patients, and the percentages that are there are based on review of literature and from our own experience. Historically, Rosai Dorfman disease was actually called as sinus histiocytosis with massive lymphadenopathy. But actually, in our experience, especially in adults, we found that lymph node involvement is not the most common involvement. In fact, the most common involvement was this skin involvement, as seen in this PET scan under the skin. That's what I see in my clinic, the most common one. But the second most common, of course, is lymph node involvement. And I believe that children may have it more frequently than adults. It can, of course, affect other organ systems of the body, like around the kidney, which can look like Erdheim-Chester disease sometimes, because ECD has similar manifestation, and it can involve bone of any bone actually in the body can be involved. It doesn't typically involve the lungs directly, but it can involve the sinuses, the nasal pathway. I've seen it manifest like polyps and can affect the respiratory tract as well. It does not usually affect the brain. It can, though. We have seen cases misdiagnosed as neurosarcoidosis. We recently had a case who carried the diagnosis of first meningioma and then neurosarcoidosis for over 10 years, and we diagnosed that patient with RDD recently. But usually it tends to affect the skull outside coating of the brain, and can also affect, of course, tissue behind the eye, which is also similar to what can be seen in Erdheim-Chester disease and IgG4 related disease. So again, you can see how many overlaps there are with other diseases, and it can be difficult to diagnose it because it can clinically mimic other disorders. This is probably the most technical slide in my whole talk today. But I think it is important because we have been hearing and talking a lot about mutations in the context of Rosai Dorfman disease. And to understand what it means, we may have to get a little bit of idea of what a normal cell does and what happens in an RDD cell. So in a normal cell, basically, this is the outside of the cell. This is the inside of the cell. We call it the nucleus. Usually there is a relay signal from the outside that goes through these 4 genes and tells the cell to multiply. So it's very tightly regulated, as you can see, as a relay signal. What happens in RDD and other histiocytosis is there is a mutation in the genes, especially in RDD in the RAS, KRAS mutation, or MEK, also known as MAP2K1 mutation. What that mutation does is it stops independently signaling this pathway, regardless of what is going on above the mutation. So it basically tells the cell to grow uncontrolled and then starts forming tumors, causing inflammation, and so forth. So these mutations have now been found in nearly 50% patients with RDD from the biopsy samples. This is not easy to find in the blood, but these are found in the biopsy samples. And these really have led to the understanding of Rosai Dorfman disease being more on the spectrum of histiocytic neoplasms, which are neoplastic, meaning because these mutations are seen in other cancers as well. And that has really opened the door for investigation of other targeted treatments and the approval of MEK inhibitors. And also now patients are able to get cancer type care, meaning PET scans and so forth, which used to be denied historically by insurance companies and so forth. There are several misconceptions about Rosai Dorfman disease in the community, both the patients and clinicians. One of the most common ones I hear from the doctors is that Rosai Dorfman disease is a benign condition. Don't need to worry about it. Leave it alone. So what happens with that is a lot of patients don't get appropriate staging. They don't get the scans they need. They don't get the testing they need. And so you may end up with end organ damage because things are not taken very seriously. So I would say it is a slow growing type of tumor or cancer, but that doesn't mean it cannot cause damage to organs. We have seen damage to various organ systems of the body in Rosai Dorfman disease. So it has to be taken seriously. So that's the first misconception. The other one is that we talked about earlier is people think that RDD only involves the lymph nodes. And we have shown that that is not the case. It can involve various other organs. And the skin image, this is from a patient that I saw, it's skin involvement is actually the most common one, at least in adults. When we talk about mutations, a common question I get from parents or patients themselves is when the word mutation comes to mind, we think about gene and genetics. And the common thought comes to mind, can I pass this RDD to my children? And the simple answer is most likely not for most cases because the mutations that occur, they occur in the tumor cells. So they're not occurring in the DNA that you transfer to your children. Now, there are some hereditary conditions that can be associated with RDD-like lesions, but they're very, very rare. And those manifest within the first few years of life. Let's talk a little bit about diagnosis and the diagnostic challenges. Part of the issue with RDD and other histiocytosis is that it often resembles other conditions. There is, on the right, I have listed some conditions that, depending on what organ is involved, patients have been misdiagnosed with. And these are from actual cases. It can resemble infections like, in developing world, like tuberculosis, autoimmune diseases, other cancers like lymphomas, retroperitoneal fibrosis, sarcoidosis, and so forth. So the diagnosis can be missed. And so when the symptoms are very subtle and the clinicians are not thinking about histiocytosis as the first thing when they see a patient, they can cause delay in diagnosis. Also when it affects uncommon areas like the brain, for example. So it's very important to raise the awareness among healthcare providers and among patients because I think patients can advocate so well for this disease in general. That will lead to early detection of RDD. The diagnosis of RDD really hinges upon looking at a biopsy sample under the microscope by a pathologist. Now, sometimes the pathologist has to do certain dye tests. So this is just images from Rosai Dorfman disease case. This image on the right shows color test or dye test, as we call them, markers that they do. And there are certain characteristics of RDD cells that help them to distinguish from LCH and, let's say, Erdheim-Chester disease. A PET scan is very important as a part of the staging or workup. As this image is showing, a PET scan typically is done from head to toe, and it can show the area where RDD might be affecting the organs. And it's almost similar to staging of a disease. There is no formal staging system, but the most important question is it affecting one organ or multiple organs? A lot of times you do blood tests to make sure there are no other conditions going on, to make sure overall health is okay. And then eventually, once the biopsy is done, a mutational testing is very important to help with the treatment selection, especially when the disease involves multiple organ systems. Usually, for example, at institutions like UAB, where I am, a multidisciplinary team collaborates to ensure accurate diagnosis and staging. So next is a little bit discussion about treatments and living with RDD. So there are many, many treatment options for RDD. So it's almost dependent on who sees the patients. And some people are familiar with one treatment versus the others because there was no standard guidelines up until 2018 for the management of Rosai Dorfman disease. But the key thing to keep in mind is that not all patients with RDD require immediate treatment. There are a few cases that I have seen for years now who have not needed treatment and they can be observed, but they have to be really carefully selected. And you have to monitor them still by means of scans and physical exam and labs and so forth. And if the RDD involves critical organs or is threatening any critical organ, like blood vessels, brain, lungs, and so forth, the treatment is needed urgently. There are many treatment options that have been used. Steroids used to be the most common treatment approach for RDD. They are slowly in our practice, we don't use them much at all now in Rosai Dorfman disease because of the side effects as well as the lack of sustained remissions. There are other immunosuppressant drugs that have been used that suppress the immunity in general. And more recently, targeted therapies like Cotellic, MEK inhibitors that inhibit that pathway that we looked at earlier were approved by the FDA, and they have been used a lot in these diseases, especially when there are multiple organs involved or a high-risk organ is involved. Sometimes surgery is important, but we have to keep in mind is that those surgeries shouldn't be very heroic or mutilating surgeries. I've unfortunately seen some cases where a part of an organ was removed, not realizing that this is a blood disorder and we can just treat it with drugs. So patients can get significant morbidity from that. In the end, it's a personalized treatment approach. One size fits all doesn't work for RDD because it affects everybody differently. So you have to keep in mind what are the symptoms, what are the organ involvement, what is the patient and family's preference in terms of treatments, and then what are the genetic mutations that can help come up with a precision approach. Nowadays, no talk about histiocytosis is complete without talking about targeted therapies and the emerging treatments, because that is quite exciting area in the field of histiocytosis. MEK inhibitors such as Cotellic or cobimetinib, they target the pathway and they are very efficacious in RDD. In one study that we did, we found that responses to MEK inhibitors were very strongly tied to what mutations they have. So patients with mutations tended to almost always respond, but patients without those mutations in the RDD biopsy still responded. There are many, many trials ongoing actually currently, which is very exciting to target the pathway a different way, different spots, the MAPK pathway to get a response. And continuous monitoring is very important once treatment is started by PET scan or CT scan and MRI, and also to manage the side effects for many treatments that patients receive. So alongside this treatment of RDD, it's very important to manage the symptoms and also provide emotional support. A lot of times patients experience uncertainty and anxiety, especially during that initial period of diagnosis and when the treatment plan is being formulated. So it is important to have a multidisciplinary team that can care for them, including psychologists, social workers, nurses, and other specialists as needed. So it's not just enough to treat the tumor. It's important to take care of the whole person and the family even. And it's very important to be involved in the association like Histiocytosis Association and Patient Registry because they offer community and advocacy. And this empowers the patients, having the knowledge will empower you, and that improves the quality of life. Last is the topic of equity research and maybe some message of hope because things are actually moving pretty quickly in RDD in the last few years. So certain groups actually may experience disparities in diagnosis as well as treatment because of it may be due to their orientation, their skin color, maybe their income status, education status, especially where I practice, I see a lot of gaps in understanding. And also depending on where they get their initial health care, they may not be geographically close by a histiocytosis center, which makes it really hard to get the care somebody needs. And so there are many barriers to access. So eventually, to improve access, outreach, education, and inclusive research practices are very important. As in academic institutions, it's really important for the institutions to prioritize equity in clinical trials or any research and in their care delivery to ensure that everybody they see benefits from all the advances and not just a handful of patients. How have we helped or we are trying to help is we formed this Histio Care Network. We started with when I was at Mayo, expanded it now when I moved to UAB, and now it includes several centers across the US. Our website is about to be launched later this month, so stay tuned for that. But the goal of this network is really to decentralize care of histiocytosis and to actually help people worldwide so that patients don't have to travel or relocate to a different place to get the care they need. And they can continue living on with their life because it can be really life altering to go with this diagnosis. So ultimately, my dream is that patients don't have to come to me necessarily to get the care they need. If there is somebody nearby who we can collaborate with to help them, that is wonderful. How can you help? I would encourage to participate in research studies wherever you are. For example, we have this large study in partnership with the Histiocytosis Association, where we are just asking you to complete a health survey from your home, comfort of your home, and there's no travel required. And we ask for your what are the health conditions, what are the symptoms you're experiencing, and anybody with any histiocytic disorder is eligible to participate. And can the survey can be done online or on a paper, whatever way works for you. And the hope is that the findings from this study will help answer this question, what to look for once this diagnosis happens, once this treatment is done. What do I expect 5 years from now? How to monitor for long-term effects? And that's really not well known in histiocytosis overall. Here is the phone number and the email address. I have it here, but this is also available through the Histio Association. If anybody is interested, they can enroll in this study. So there is growing hope in the field of histiocytosis, including and especially Rosai Dorfman disease. I think advances in molecular diagnostics, targeted therapies, and patient advocacy, they're really transforming care. I would say that the patient and family should be encouraged to stay informed, seek second opinions, and engage with support networks like this one. Ultimately, advocates and policymakers have to work together because funding is so critical, and especially in the current environment, it is very important to make sure that there is funding to fund research as well as the awareness efforts. And together, I'm very confident that we can improve outcomes and build a brighter future for those affected with RDD and other histiocytosis. With that, I will end. I think I'm over time. This is our team, and they work tirelessly on our research studies and our efforts. And this is our contact information if anybody would like to reach out to us for any questions or if they're interested in participating in our survivorship study. And I will take questions now. Thank you.